doctors, welcome to DigiNow. In this module, we will discuss about pancreaticoduodenectomy, also known as Whipple surgery. I am Dr. Sunil Senvi, GI, HPB and multi-organ transplant surgeon. What are the learning objectives for this module? To understand the indication and patient selection criteria for pancreaticoduodenectomy, we will review the key operative steps and anatomical considerations. We will recognize major post-operative complications and their management strategies. We will compare open versus minimally invasive approaches for pancreaticoduodenectomy. We will also discuss the recent controversies and evolving practices in pancreaticoduodenectomy. The first successful operation for periampullary cancer was done by William Halstead at Johns Hopkins in 1898. First pancreaticoduodenectomy was performed by Dr. Cordwilla, but the patient did not survive in the post-operative period. First two-stage pancreaticoduodenectomy was done by Kocher in 1909. Subsequently, pancreaticoduodenectomy was done as a single stage procedure by Herschel in 1914. Dr. Whipple refined the procedure in 1935. They can frame a MCQ on this historical context in your INA SS, so be aware of the surgeons. Moving on to indications for Whipple's procedure. Whipple's procedure or pancreaticoduodenectomy is indicated for benign, pre-malignant or malignant conditions of the pancreas or duodenum. It is a surgery for pancreatic head adenocarcinoma, ampullary carcinoma, distal cholangiocarcinoma, duodenal adenocarcinoma which arises near ampulla. Whipple surgery is also indicated in chronic pancreatitis with intractable pain localized to head of the pancreas, or if there is a head mass in patients with chronic pancreatitis where you are not sure whether it is malignancy or it is just a benign mass. Whipple surgery is also indicated in IPMN or other cystic neoplasms which has high risk features. It is also a surgery for neuroendocrine tumors of pancreatic head. The other indications for pancreaticoduodenectomy are trauma involving pancreatic head or duodenum, where it is called as trauma Whipple. It is also done for rare tumors like SPEN. What are the contraindications for Whipple's procedure? The absolute contraindications are presence of distant metastasis like metastasis in the liver, in the peritoneum or in the lung. If there is unresectable vascular invasion to the celiac axis, supramesenteric artery or portal vein where the reconstruction is not possible, that is the absolute contraindication. Remember that if there is a portal vein invasion by the adenocarcinoma, but you are able to reconstruct the portal vein or resect the portal vein, then it is not a contraindication for Whipple surgery. If the patient has poor general conditions or severe comorbidities which preclude performance of major surgery, it is also absolute contraindication for Whipple's procedure. What are the relative contraindications? Locally advanced tumors with involvement of multiple critical vessels or severe malnutrition or poor performance status of the patient. In these patients, you can try to optimize the patient before surgery. If you are able to optimize, you can take up the patient for surgery, otherwise it is a relative contraindication. Before moving on to surgery, let us revise the superior mesenteric vein anatomy, which is particularly important for Whipple's procedure. Superior mesenteric vein usually bifurcates into two main branches, one to the ileum and one to the jejunum. You can appreciate here the ileal branch and the jejunal branch. Adequate venous return from the small bowel requires at least one of these two tributaries. Adequate venous return from the small bowel requires at least one of these two SME tributaries to remain intact. The jejunal branch of SMV, which is also known as first jejunal branch, okay, you will hear this name frequently when you are discussing about Whipple's procedure. The first jejunal branch, as the name suggests, it drains the proximal jejunum. This branch is typically posterior to the SMA. You can appreciate here, that is the SMA, and the first jejunal branch is posterior to the SMA, and it enters the SMV along its posterolateral wall. Rarely jejunal branch travels anterior to the SMA. Let us discuss about the pancreaticoduodenectomy surgery. It has three important components. First is exploration, second is resection, and third is reconstruction. Okay. So, remember this. First, you will explore the abdomen and look for any distant metastasis or anything which indicates unresectability. After that, you will resect the specimen, and finally, you will do the reconstruction. What incision you will use? You can use a midline incision, or you can use a bilateral subcostal incision. Nowadays, people are also using Makuche incision. So, these three are the incisions which are generally used for Whipple's procedure. The important steps of pancreaticoduodenectomy, you can divide it into 8 steps. Firstly, the exposure of infrapancreatic supermesenteric vein, then you will do the extended Kocher's maneuver, then you will do portal dissection, subsequently you will transect the stomach, then you will transect the jejunum and dissect the ligament of Treats. Subsequently, you will transect the pancreas and complete the retroperitoneal dissection by removing the specimen from supermesenteric vein and supermesenteric artery. Sometimes people will do extended Kocher's maneuver first, and then they will proceed to exposure of infrapancreatic SMV. So, when you start the exploration, you will inspect the peritoneal surfaces for any metastatic disease. You will also look for liver metastasis or any metastasis anywhere else in the abdomen. After that, you will start mobilization. In Kocher's maneuver, you will do the mobilization of the duodenum and head of the pancreas. You will start from the right side and you have to reach to the left lateral border of the aorta. You will also separate the transverse mesocolon from the pancreatic head, thus exposing the infrapancreatic supermesenteric vein. We will enter the lesser sac via gastrocolic ligament, and while doing so, you will preserve the gastroepiploic vessels. We will ligate the right gastroepiploic vein at the SMV confluence. We will also mobilize pancreatic head and gallbladder. Very rarely you may have to sacrifice the middle colic vein. Remember about gastrocolic trunk. This is also called as registrar's vein. Okay, registrar's vein. If you are first time assistant for a Whipple's procedure, you don't know how to retract, and then if you do extraction, the gastrocolic trunk which drains into the SMV can get avulsed and there can be lot of bleeding. Okay, it is easy to control, but you have to be careful. Avoid avulsion of the gastrocolic trunk. In this figure, you can appreciate the Kocher's maneuver, which is done by identifying the infravena cava at the level of proximal portion of transverse segment of duodenum D3. Okay. So, you can see here the Kocher's maneuver is being performed. When you are doing a Kocher's maneuver, you have to be in the right plane. Okay. So, if you go into the wrong plane, you can go very near to the kidneys, okay, or you can injure the gonadal vein. So, remember to be in the right plane when you are doing a Kocher's maneuver. After this, you will enter the lesser sac, you will take down the hepatic flexure, you will identify the inferior body of the pancreas at the level of the proximal body of the gland. SMV is exposed at the inferior border of the neck of the pancreas adjacent to the uncinate process. You can appreciate here, that is the tumor, this is where the uncinate process is there, and this is the part you are going to expose. Okay, that is the superior mesenteric vein at the inferior border of the neck of the pancreas, just adjacent to the uncinate process. This is tunnel of love. Okay, so tunnel of love, if you are able to create the tunnel of love, it means the disease is resectable. Before you proceed with the irreversible step in the pancreaticoduodenectomy, which is an irreversible step in pancreaticoduodenectomy, is transection of the neck of the pancreas. Once you transect the neck of the pancreas, then you cannot come back. Okay, then you have to proceed with the surgery. Before doing that, how will you make sure the disease is resectable or no? Okay, so what you do is you create a plane between the neck of the pancreas and portal vein. Portal vein is just behind the neck of the pancreas. If you are able to create a tunnel between the neck of the pancreas and the portal vein, it means the disease is resectable. Okay, so generally this plane is avascular. Okay, there are no tributaries from the neck of the pancreas draining into the anterior surface of the portal vein. Okay, so you have to create a tunnel of love before doing a irreversible step in the vessel, before doing a irreversible step in the Whipple, that is pancreatic neck transection. You can see that is the tunnel of love. You can appreciate the fingers are inserted behind the neck of the pancreas. In front of the portal vein there is a nice plane. That means you can proceed with the surgery, the disease is resectable. Remember about the tunnel of love, which is in relation to portal vein and the neck of the pancreas. Let us discuss about other vessels you will encounter and how will you deal with it. Firstly, the common hepatic artery identification. Generally there is a large lymph node sitting in front of the common hepatic artery. You have to remove the large lymph node anterior to common hepatic artery. It is fairly common. And then the common hepatic artery is followed distally. You will divide the right gastric artery, you will also divide the gastroduodenal artery. Okay, remember you have to divide the gastroduodenal artery, and this is an important artery. Post pancreaticotomy hemorrhage, which can happen because of GDA pseudoaneurysm. So it is very important to tie this artery properly. Okay. After dividing right gastric artery and GDA, you will mobilize it off the anterior surface of the portal vein, okay, on the lesser omentum. You have to identify the portal vein before dividing the common hepatic duct to avoid vascular injury. Okay, it is very important to identify portal vein before you divide the common hepatic duct, otherwise you can injure the portal vein if you do it blindly. You will remove the gallbladder as a part of Whipple surgery. You will do a circumferential dissection of the common hepatic duct because you have to transect it completely. You will divide the duct, you will expose the suprapancreatic portal vein, okay. The portal vein which is behind the common hepatic duct will be identified. If you are doing pyloric preserving pancreaticoduodenectomy, PPPD, okay, then you will divide the duodenum more than 2 cm distal to pylorus. We will come back to this. Okay. So just remember that when you are doing pylorus preserving pancreaticoduodenectomy, you are going to divide duodenum more than 2 cm distal to pylorus. We will expose the hepatic artery proximally and distally, and we will check for variant anatomy, especially replaced right hepatic artery. We discussed about ligating right gastric artery and ligating and dividing gastroduodenal artery. Before dividing gastroduodenal artery, you have to do a test clamp of gastroduodenal artery. Okay. So what will you do is you will put a bulldog clamp to the gastroduodenal artery and feel for the pulsations in the hepatic artery. If there is celiac artery stenosis, then if you put a bulldog clamp on the GDA, the pulsations in the hepatic artery will disappear. So that means the blood is coming through the GDA into the hepatic artery because there is celiac artery stenosis. So before ligating GDA, you have to do a test clamp of GDA. It confirms the arterial flow. You can also do a Doppler if you are not comfortable palpating the flow into the hepatic artery. If the flow is maintained, you will ligate and divide the GDA. If the flow is compromised, then you have to preserve the GDA or you have to perform the arterial resection or bypass. Remember this point. After this, the antrum of the stomach is resected with the main specimen, dividing stomach at the level of third or fourth transverse vein on the lesser curvature of the stomach. Okay, you can appreciate here, there are transverse vein here. Okay, you can see the blue things. This is the main vein on the lesser curvature, and then there are transverse branches. So you will divide the antrum of the stomach at the third or fourth transverse vein on the lesser curvature, and when you do that, it is called as classical pancreaticoduodenectomy or classical Whipple procedure. Sometimes you will try to preserve the entire stomach, and when you preserve the entire stomach, it is called as pylorus preserving pancreaticoduodenectomy, PPPD, or pylorus preserving Whipple's procedure. Okay, remember this. And where do you transect duodenum when you are doing PPPD? It is more than 2 cm from the pylorus, that's where you will transect the duodenum. You will also divide the pancreas after ligating superior and inferior pancreaticoduodenal arteries. You will divide the jejunum 10 cm distal to the ligament of Treats. Okay. Now you are coming in the infracolic compartment. You have to divide the jejunum 10 cm distal to the ligament of Treats. You will divide the short mesenteric vessels, and by doing this, it will allow you to rotate the jejunum and duodenum from the infracolic compartment to the supracolic compartment. So same thing what we discussed just now, you will transect the jejunum followed by ligation and division of its mesentery. You can appreciate here, the jejunum has been transected here, and then you are ligating and dividing the mesentery. The loose attachment of ligament of Treats is also taken down. Okay, this we discussed. The duodenum and jejunum is then reflected underneath the mesenteric vessels in preparation for the final and most important part of the pancreaticoduodenectomy. Okay, so you can appreciate here, once you have transected the jejunum and you have divided the mesentery, you are going to pull the proximal part of the jejunum on the upper part. Okay, and once you have jejunum there in the supracolic compartment, you are going to start doing the most important and the final part of pancreaticoduodenectomy. So when you start the final part, you will retract the specimen rightwards and you will complete the portal vein and uncinate process dissection. You will expose the superior mesenteric artery and dissect the retroperitoneal tissue. You will also clear the periarterial lymphatic tissue. If you find any venous involvement, if there is less than 50% circumferential involvement, you can remove the part of the vein and do a primary repair. If there is more than 50% involvement or segmental involvement of the portal vein, you have to do a segmental resection with primary anastomosis if possible, or you have to put a interposition graft. And where do you take a graft? You can take internal jugular vein or femoral vein. For interposition graft, you will use internal jugular vein or a femoral vein or a PTFE graft. So this is what we were discussing. The pancreatic head and the uncinate process is separated from the superior mesenteric and portal vein confluence. You can appreciate here, that is the superior mesenteric vein, this is the portal vein, and that is the splenic vein, and you are separating the superior mesenteric vein SMV confluence from the pancreatic head, and that is the first jejunal branch which we discussed. The pancreas is transected at the level of portal vein and the pancreatic head is reflected laterally, and this will allow you to identify small venous tributaries which are draining the head of the pancreas and the uncinate process into the SMV and the portal vein. You can appreciate there are small venous tributaries which are draining the head of the pancreas and uncinate, which have been ligated and cut. Okay. So after this, you will do a medial retraction of the superior mesenteric portal vein confluence, which will facilitate the dissection of the soft tissues which are adjacent to the lateral wall of the proximal superior mesenteric artery. So what happened here is, you have freed the superior mesenteric vein, portal vein, and after that you are going to reach the superior mesenteric artery. Okay, that is the superior mesenteric artery. Okay, you have freed the portal vein, superior mesenteric vein, and that is the vein retractor. You will retract the vein and then you will see the supramesenteric artery, and now you have to ligate the branches of the supramesenteric artery to the head of the pancreas or the uncinate process. And the most important artery here is inferior pancreaticoduodenal artery. That is the first artery you are going to try. Okay, that is the first artery you are going to tie, inferior pancreaticoduodenal artery. You can appreciate here. So when you are doing that, there is something called as mesopancreas. Okay, and you have to remove the mesopancreas to get a R0 resection. So mesopancreas is a fibrous tissue plane behind the pancreatic head. You can appreciate here, that is the mesopancreas. This shaded part is the mesopancreas and that is the SMA. Okay, and this is the inferior pancreaticoduodenal artery which you are going to ligate. So this mesopancreas contains lymphatic nerves and vessels of supramesenteric artery, celiac axis. This area is critical for R0 resection in pancreatic head cancers. It is not a true anatomical mesentery, but it is functionally similar. If you reset the mesopancreas, then it gives you a very good oncological clearance. If there is any tumor involvement in mesopancreas when you are doing resection, then probably you will have a positive margin on the final histopathology. Okay, so that is the clinical significance of mesopancreas, and make sure that when you are doing Whipple's procedure, when you are approaching supramesenteric artery, you get rid of mesopancreas completely. Sometimes you have venous involvement which we described. So in this picture you can see the tumor is abutting the vein, maybe involving the vein. Okay, in that case you may have to resect the vein completely or just resect the part of the wall of the vein and then just do a primary anastomosis or put a patch. Sometimes you have to put an interposition graft. So know about the venous involvement in Whipple's procedure. The venous reconstruction has been classified from type 1 to type 4. So in type 1, if you have to resect a small part of the vein and then you will be able to do a primary repair of that part, then it is type 1. If you have to apply a patch there, then it is type 2. If you have resected a part of the vein but you are able to do end-to-end anastomosis, then it is type 3. Type 4 is when you have to do a interposition graft. If you have to do a interposition graft below the confluence of splenic vein, then it is type 4A, but if you have to implant the splenic vein into the interposition graft, then it is type 4B. Okay, so they can frame a question in INI SS on this. So remember this part. But other thing is, involvement of the portal vein is not a contraindication for Whipple surgery. Remember that. Even if there is tumor which is involving the portal vein, it is classified as a resectable disease. So once the resection is complete, this is how the specimen looks. Okay, you can appreciate here, that is the C-lip of duodenum, that is the pancreatic head, that is the gallbladder, cystic duct, and somewhere here is the part of the CBD. Okay, so this is a resected specimen of Whipple's procedure. In INI SS or NEET SS, they may give you this picture and ask you this specimen belongs to which surgery. Okay, so be clear about this. After you resect, we do something called as painting of the margins. Okay, to help the pathologist to tell us whether the margins are clear or no. So there is something called as Leeds protocol. Leeds protocol, and where you mark the margins with a special paint, and it will help your pathologist to tell you whether the margins are free or involved. Okay, Leeds protocol has been asked as an MCQ in previous NEET and INI SS. Okay, remember this term, Leeds protocol. So Leeds protocol is basically from Leeds Hospital in UK. So that is about Leeds protocol, and this is the resected specimen of Whipple's procedure. On the other two pictures, you will appreciate the important structures once you have resected the specimen. I need to know that. You need to know the bed after removing the specimen, what all structures you will be able to see. And again, this can be given as a picture in NEET SS or INA SS, and they will ask you to identify the structures seen in the picture. You can see that is the supramesenteric vein, this is the transected neck of the pancreas, this is the portal vein, okay, and here is the gastroduodenal artery which has been ligated, and this is the common hepatic duct, okay. Same thing, the supramesenteric vein, and that is the supramesenteric artery here. So when you with the vein retractor, when you pull the portal vein towards the left side, you will see the supramesenteric artery, okay, and we discussed about the significance of Mesopancreas. So that's about the Whipple bed after you have resected the specimen, okay. Once you have resected, the last step is you have to do the reconstruction. This is the last step. Many people will send frozen section of the pancreatic neck margin to make sure that the margins are negative, especially when you are doing surgery for IPMN and all, okay. You have to wait for the frozen section. Remember that you have to mobilize around 2 centimeters around the neck of the pancreas, so that you will be able to do anastomosis nightly, okay. When you are waiting for frozen section, you will mobilize the neck of the pancreas for around 2 centimeter to make that anastomosis get simple. We will bring the proximal jejunum, the transected part of the distal part of the jejunum, that we will bring into the supracolic compartment through the mesocolon by doing a defect in the transverse mesocolon, okay. And what are the three anastomosis generally we do is pancreaticoduodenectomy, hepaticojejunostomy and duodenojejunectomy or gastrojejunectomy, okay. So once you have resected the pancreas at the neck of the pancreas, you have to restore the continuity of the pancreas with the intestine, and for that you will do pancreaticojejunostomy. If the pancreatic duct is very small, you sometimes do pancreaticogastrostomy, but most commonly done procedure is pancreaticojejunostomy. And how will you do? The anastomosis is 2-layer anastomosis, and the most commonly done technique is duct to mucosa anastomosis. You will do anastomosis of the pancreatic duct with the mucosa of the jejunum, and then you will anastomose the second layer, the serosa of the jejunum with the tissues of the pancreas, okay. So the 2-layer anastomosis is done, and it is duct to mucosa pancreaticojejunostomy. People also leave internal stent if the duct diameter is less than 5 mm, or you can also put a external stent. Previously we used to put external stent, so there used to be a feeding tube which we used to insert into the pancreatic duct and then bring it out through the jejunum, through the parietal wall, and we used to make it hang, okay. That is the external stent, okay. Nowadays many people do not do that. So what we just do is a internal stent, okay. We put a stent, the one end is in the pancreatic duct and the other end is in the jejunum, and this stent will fall off with time. The other anastomosis we do is hepaticojejunostomy. We know that we have removed the gallbladder and we have cut the hepatic duct, the common hepatic duct. So you have to restore the continuity of the biliary tract. So what you do is hepaticojejunostomy, okay. And you may have to spatulate the duct if it is less than 5 mm diameter, and then we know that you have cut the stomach or the duodenum. So you have to do the duodenojejunostomy or gastrojejunectomy. This is the final step, that is, by doing this you will restore the gastrointestinal community, gastrointestinal continuity. And as I discussed, I told you why we resect the pancreas and duodenum together when you are doing a Whipple's procedure. It is because there is a shared blood supply between the pancreas and the duodenum. So if there is a malignancy in the pancreatic head, you will remove the head of the pancreas with duodenum. You cannot leave duodenum there and just remove the pancreatic head. The duodenum will get devascularized. Similarly, if there is tumor in the duodenum, okay, you will also remove the pancreatic head, because if you just remove the duodenum itself, it is going to be extremely challenging, and then risk of devascularization of the pancreatic head. That is why, because of the shared blood supply, you are going to remove both of them together. Remember this concept. So once you have done reconstruction, finally you will place drains near the anastomosis. Nowadays less and less drains are being put. Previously they used to put multiple drains. Now people put either one or maximum 2 drains, and there are some surgeons who don't put drains at all, because with the advent of intervention radiology, so even if you need any drain in the post-operative period, you can ask them to put a pigtail drainage. So few surgeons are not putting drains, but majority of the surgeons put either one drain or 2 drains near the anastomosis. Okay. There is also concept of doing feeding jejunostomy. Okay. The patient is severely malnourished, or many people do routinely feeding jejunostomy. Some people prefer to put a NJ tube at the end of surgery. Okay. And feeding jejunostomy is especially done if the patient is malnourished, indicated by the albumin level less than 3.5. Okay. So remember about need of feeding jejunostomy or nasojejunal tube and need of external drains near the anastomosis. So this is the technique of pancreaticoduodenectomy. So you can see here, that is the posteriormost layer anastomoting the pancreatic tissue to the serosa, and then you will do the anastomosis between the duct of the pancreas with the mucosa of the jejunum. You will come anteriorly, and then finally you will complete the entermost layer between the pancreatic body and the cirrhosis of the jejunum, and that is the internal stent which has been inserted. The one end is in the pancreatic duct, the other end is in the jejunal lumen, and these are the drains which you have put around the anastomosis. Okay. This is how pancreaticoduodenal anastomosis is done, PJ. Okay. We also do similarly, but what we generally follow is, for pancreatic duct, before doing the posteriormost layer, we put a pre-placed sutures into the pancreatic duct. So that is a little different from what other people do, but most of them are almost similar. Some people have few minor variations. Remember that there are 100 different ways of doing a pancreaticoduodenal anastomosis. There is something called as dunking. If you are not able to find the pancreatic duct, you will just put the pancreatic stump into the lumen of the jejunum, which is called as dunking. Okay. So there are multiple methods. You just have to master one method and stick to it. And most commonly done procedure is pancreaticoduodenectomy, duct to mucosa anastomosis, which is being followed by many surgeons across the globe. Okay. So this is the same thing. You can see the anastomosis being done here, PJ being done, and that you can appreciate there is a pancreatic stent there, internal pancreatic stent, and this is how the final anastomosis looks like. Okay. That is the transected part of the jejunum. If they ask you what is the distance between the anastomosis and the transected part, that is generally around 3 centimeter. Remember that. Okay. That is around 3 centimeter, and this is how it looks at the end of surgery. This is how the pancreaticoduodenal anastomosis looks like. Okay. And after that you will do a anastomosis between the common hepatic duct and the jejunum. This is called as hepaticoduodenestomy. Okay. You will generally transect the duct above the insertion of the cystic duct. Remember that. Okay. And what is the length of this part is around 15 centimeter. Okay. This is around 15 centimeter. You can do continuous method if the duct size is larger. If it is smaller, you will do the interrupted sutures. You generally use PDS. Okay. Both for PJ and for HJ, we generally use PDS. And this is the final step. Okay. If you have done a classical PD, you will anastomose the stomach to the jejunum, and if you have done pylorus preserving pancreaticoduodenectomy, okay, you will anastomose the duodenum to the jejunum. Okay. So that is, this is the gastrojejunostomy, or this is duodenojejunostomy. This is classical PD or Whipple's procedure, classical Whipple's procedure, and this is pylorus preserving pancreaticoduodenectomy. Okay. Remember this. So what are the structures which are being removed in Whipple's procedure? You will remove the duodenum, C loop, you will remove the head of the pancreas, you will remove the gallbladder, and you will remove the distal part of the extrahepatic biliary tree, that is below the insertion of the cystic duct. So these are the structures removed, apart from the lymph nodes and the tissues, mesopancreas, all the structures are removed in the Whipple's procedure. So if they ask you structures removed in the Whipple's procedure, you will be able to tell. If they ask you what are the anastomosis, okay, This is the PJ, you will do a HJ and you will do the anastomosis between stomach or duodenum with the jejunum. What is the length of this part? Generally around 25 to 30 centimeter. Okay. Remember this also, 25 to 30 centimeter. From the HJ to the anastomosis between the stomach and jejunum or duodenum and jejunum is around 25 to 30 centimeter. So, be very clear about all these parts. Moving on to role of extended lymphadenectomy in pancreatic cancer. For defining extended lymphadenectomy, generally we use Japanese Pancreas Society lymph node staging system. According to that, there are 3 types of lymphadenectomy for pancreatic cancer. When you do a pancreaticoduodenectomy, it can be standard, it can be radical or it can be extended radical. For body and tail tumors, you can do a standard lymphadenectomy or radical lymphadenectomy. What is the evidence with respect to extended lymphadenectomy in pancreatic cancers? There are various prospective non-randomized studies. Based on these studies, there is no significant difference in survival or mortality if you do extended lymphadenectomy or you don't do extended lymphadenectomy. The patient who have undergone extended lymphadenectomy have more post-operative diarrhea, but there are some bias in these studies. Other studies show that whether you do standard lymphadenectomy or extended lymphadenectomy, there is similar morbidity and survival across groups. There are a couple of RCTs. There are 4 major RCTs. In RCT by Petrazzoli et al., there was no survival or mortality benefit if you do extended lymphadenectomy, but when they do a subgroup analysis, they found that there is benefit in node positive cases in extended lymphadenectomy group. In study by Yo et al., which is the largest randomized control trial with 294 patients, there was no survival benefit with extended lymphadenectomy. There was higher morbidity in patient who underwent extended lymphadenectomy, and if you do a extended lymphadenectomy, they found that there is higher incidence of delayed gastric emptying and pancreatic fistula. Other randomized control trials also did not confirm any survival advantage with extended lymphadenectomy. So, what is the conclusion? Extended lymphadenectomy in pancreatic cancer does not improve long-term survival. It is associated with higher morbidity. It reduces quality of life. So, the current standard is during pancreaticoduodenectomy, you will only do standard lymphadenectomy. Okay, you are going to remove only the lymph nodes around the pancreas. You are not going to do extended lymphadenectomy. Okay, so that's the standard. Moving on to vascular resection in pancreatic cancer. The vascular resection in pancreatic cancer was proposed by MSKCC group 30 years ago. Before that, if there was any vascular involvement, even the venous involvement, the disease was considered as unresectable. Okay, but MSKCC group proposed that if there is venous involvement, you can do en bloc resection and you can try to cure the disease. Okay, so by doing more radical resection with help of vascular resection, there will be better tumor clearance and this can improve the survival of the patient. What is the current evidence with respect to vascular resection in pancreatic cancer? We don't have any RCTs. What is our approach for vascular resection? If there is SMV or portal vein resection, we generally do resection, and I told you it is not a contraindication for resection. Okay. If there is need of isolated hepatic artery resection, we don't do it. We don't do SMA resection, but there are some centers in the world who do hepatic artery resection or SMA resection if they are involved in well selected cases. Okay. We don't do it, but there are some people in the world who are doing it. So, what is the literature with respect to vascular resection in pancreatic cancer? There is wide heterogeneity in the outcome. It is influenced by surgical expertise, perioperative care and institutional volume. There is comparative long-term survival between pancreaticoduodenectomy with or without vein resection. If you are working in a high volume center, you can do portal vein or SMV resection safely, then you can proceed with it. Venous involvement, again I am telling, is not a contraindication if the resection is technically feasible. Okay. With respect to arterial resection, Hepatic artery resection we don't do, but it can be done selectively. SMA involvement we don't do resection because it has poor prognosis, there is high perioperative mortality, there is no survival benefit by doing SMA resection. So currently it is not recommended, it is not a standard of care. There was a question in recent INA SS or NEET SS, I don't remember currently, but they asked you about triangle operation. Okay, so they asked you about triangle operation is done in which cancer. Okay, the triangle operation is done in pancreatic cancer. This is a new concept which has come in. Okay, so this is more radical resection in pancreatic cancer. It involves removal of soft tissues, lymphatics and nerve plexus around celiac axis, superior mesenteric artery and mesenteric portal axis, and together all these three form a triangle region. Okay, previously when we used to do Whipple's procedure, when I was a SR or a JR, whenever we used to do Whipple's procedure, we never focused on this triangle area, we never cleared the lymph nodes around the celiac axis at that time. Okay, but subsequently it was realized that if you want to really do a radical resection, arterial resection, you have to also clear this triangle region. You can appreciate here, that is the triangle, this is the triangle, and you have to clear the tissues, okay, in this region. So remember, triangle operation in pancreatic cancer, the same thing, the intraoperative pictures of triangle operation in pancreatic cancer. Remember that the triangle operation can be done for head of the pancreas or also in the body tail of the pancreas. Okay, this is not exclusively for head of the pancreas. Okay, it is also part of surgery for adenocarcinoma or any tumor which is malignant in the body or tail of the pancreas. SMA first approach in pancreaticoduodenectomy we discussed when we are doing a Whipple's procedure. We first go to the superior mesenteric vein. Okay, but there are people who first go to the SMA, that is called as SMA first approach. Okay, before the advent of very good radiological modalities, even though it is resectable, still you may have to go and look at the SMA before doing a irreversible step. So that's why they came up with SMA first approach. There are different kind of SMA first approaches, the posterior approach, right medial approach, anterior approach, superior approach, inferior approach and left posterior approaches. There are 6 different types of SMA first approach. There are few surgeons till today they do SMA first approach, especially in borderline resectable tumors, okay, or you are not sure whether the SMA is free or no. But with advent of diagnostic modalities, nowadays less and less people are doing SMA first approach, but you need to know about this. When I gave my MCH exit exam, this was asked to me, SMA first approach. They discussed in detail about, the examiner asked me in detail about SMA first approach. So you need to know about the SMA first approach. The other recent concept with respect to Whipple procedure is arterial divestment. They have not asked about this in any recent NEET or INA SS, but I think they are going to ask you about this, the arterial divestment. So what do you do in arterial divestment? It is in relation to superior mesenteric artery. Okay, remember, arterial divestment is with respect to SMA. So in arterial divestment, you will do sharp dissection of the tumor of the arterial adventitia, but you will not resect the artery. Okay, you will do a sharp dissection of the tumor of the arterial adventitia. Sometimes people do the sub-adventitial dissection. They take out the adventitia without resecting the artery. The indication for arterial divestment is borderline resectable or locally advanced pancreatic cancer where there is arterial abutment. The principle behind arterial divestment is skeletonization of artery to be done while preserving the luminal integrity of artery. The rationale is, by doing this you are aiming at R0 resection. What are the risks? You can injure the artery wall, there can be bleeding, pseudoaneurysm, and you may have to convert from divestment to resection and anastomosis. What is the role? It is adjunct to SMA first approach or triangular resection approach. Okay, so know about arterial divestment, they can ask an MCQ on this. What is the role of multivisceral resection in pancreatic cancer? About 35% of the patient who have locally advanced pancreatic cancer will have a contagious organ involvement. It is more common in body and tail of the pancreas cancers rather than head of the pancreas cancers. what is the rationale behind multivisceral resection? Again, to achieve arterial resection, that is margin negative resection, and arterial resection is critical for long term survival in patients with pancreatic cancer. What are the structure you may have to remove? Mesocolon, colon, adrenal gland, liver or stomach. Okay, there is something called as ramps procedure. The posterior ramps, you will remove the adrenal gland in body and tail of the pancreatic cancer. Okay, remember the structures removed can be mesocolon, colon, adrenal gland, liver or stomach. Okay, so what is the evidence with respect to multivisceral resection? Some studies have reported increased morbidity and limited survival benefit. The other studies, including a famous study by Sasson et al., shows that there is perioperative morbidity of 35%, which is similar to the standard resection. Mortality is around 3%, again it is similar to standard resection. Operative time obviously will be longer if you are doing multivisceral resection. The blood loss and hospital stay will also be higher if you are doing multivisceral resection. Survival after multivisceral resection are not significantly lower than standard resection. Survival is better than non-resected patient. Obviously, if you can achieve arterial resection, the survival will be better. Okay, if you do R1 resection, survival will be poor. But when you are doing a bigger surgery, you are doing multiple resection, the morbidity will be higher. Okay, and as I told you, multivisceral resection is more applicable in left-sided pancreatic cancer, that is body and tail pancreatic cancers. Moving on to the outcome of surgery. Okay, perioperative mortality and long-term survival. So, other thing to remember is when you are doing a Whipple's procedure, the patient is at high risk of developing thromboembolism. So, it is very important to put the patient on thromboprophylaxis. Remember this, if you are doing a Whipple surgery, make sure that the patient is put on thromboprophylaxis after doing surgery. It is very important. Moving on to perioperative mortality and long-term survival after Whipple's procedure. The perioperative mortality after Whipple procedure is less than 2% in high volume centers. Morbidity is common around 30 to 50%. Remember these figures, mortality less than 5%, morbidity is around 30 to 50%. Median survival after resection with adjuvant therapy is around 22 months. Okay? Remember, the median survival for pancreatic cancer after Whipple's procedure is 22 months, around 2 years. 5-year survival is between 15 to 20%. Okay? The disease relapse occurs mainly at metastatic site, okay, 85%, and there can be local recurrence in 40% of the patient. Without resection, only with palliative chemotherapy, the survival is half, that is around 10 to 12 months. If there is metastatic disease, the survival is around 6 months. Okay? So, by doing surgery, you are giving them the average survival of 22 months. If you do not do surgery, if it is locally advanced, 1 year survival, if it is metastatic disease, around 6 months survival. Moving on to morbidity of Whipple's procedure, as I told you, the morbidity is around 30 to 50%. This table is from Saviston textbook. If they ask you what is the most common complication or most common morbidity after Whipple's procedure, it is delayed gastric emptying, okay, commonly written as DGE, delayed gastric emptying, around 18%. The next common complication is pancreatic fistula, okay, commonly written as POPF, post-operative pancreatic fistula. Here it is written as 12%, but we generally see around 15 to 20%. Okay, we will come back to this. Wound infection 7%, intraabdominal abscess 6%, cardiac event 3%, bile leak 2%, and overall reoperation is 3%. Okay, that is the outline of morbidities after pancreaticoduodenectomy. We will discuss one by one because this is important. If you are giving your NEET SS for MCH GI surgery or DNB GI surgery, they are going to ask you about morbidities, okay, and you have to be thorough with all these things. The most common morbidity after pancreaticoduodenectomy is delayed gastric emptying. It can occur anywhere between 15 to 5%. It can occur anywhere between 5 to 15%. What is the definition of delayed gastric emptying? Prolonged nasogastric decompression or inability to tolerate oral intake. Okay, generally once you do a Whipple's procedure, we will keep rice tube for 1 to 2 days. By day 3, we will remove the rice tube and allow the patient orally. But if there is need of prolonged nasogastric decompression, or if the patient is not tolerating orally, you will label it as delayed gastric emptying. Okay. People used to say that if you do a pilose preservation, then the incidence of DG is lesser, but subsequently it was found that there is no difference. In fact, some studies show that with pilose preserving pancreaticoduodenectomy, the chances of DG are higher. Before labeling somebody as DGE, you have to do a cross-sectional imaging to rule out secondary causes like presence of pancreatic leak or presence of pancreas. Whenever there is pancreatic leak or abscess at the anastomotic site of PJ, there will be gastroparesis because the stomach will be just anterior to the PJ. There is any collection or PJ leak, it will irritate stomach and gastroparesis. So, if there is any pathology which you can see on CT, then you cannot label it as DGE. Okay. So, to label somebody as DGE, you have to make sure that there is no secondary causes like pancreatic leak or abscess. You may also have to do structural evaluation by imaging or endoscopy. For example, if you suspect that the anastomosis between the stomach and the jejunum is tight, okay, you may have to do endoscopy. And whenever the patient has DGE, you have to make sure that you are maintaining the nutrition by enteral feeding, either if you have a FJ well and good, or you may have to insert a NJ in these patients till the DGE recovers. International Study Group of Pancreatic Surgery, okay, ISGP, okay. International Study Group of Pancreatic Surgery have given a grading system for delayed gastric emptying. Okay. DG has been graded as grade A, grade B and grade C. Okay. What are the things you look for to grade as A, B, C? You will look for nasogastric decompression duration or inability to tolerate solid food by POD. Okay. So, if the patient needs nasogastric decompression from post-op day 4 to 7, or you may have to reinsert the Riles tube on POD 3 or after POD 3, again it is grade A. Okay. The patient is not tolerating orally on POD 7, again it is grade A. If you have to reinsert the Riles tube after day 7, or if the patient is needing Riles tube up to 2 weeks from day 8 till day 14, it is grade B. If the patient needs Riles tube for more than 14 days after surgery, or if he is not tolerating orally for 3 weeks, it is grade C. This is International Study Group of Pancreatic Surgery grading system for delayed gastric emptying. Remember, this can be asked as a MCQ in INSS. Moving on to the other morbidity is pancreatic leak or pancreatic fistula. It occurs in 5 to 22% of the cases. What is the definition? ISGPS definition of post-op pancreatic fistula is drain output of any measurable volume of fluid on or after POD 3 with amylase content greater than 3 times the serum amylase activity. This ISGPS definition was given in 2016. We had a different definition before 2016. There was one definition which was given in 2005, but the recent definition is from 2016, and you have to remember this definition. What is it? Drain output of any measurable volume of the fluid on or after POD 3 with amylase content greater than 3 times the serum amylase activity. Okay. Generally, when you have done a Whipple's procedure, what we do is on day 3 we send the drain amylase and we will send the serum amylase. Okay. We consider the upper level of the serum amylase as standard, and if your drain amylase is 3 times more than that, then it confirms the pancreatic leak or pancreatic fistula. Okay. Remember the serum amylase. So, imagine that the serum amylase is 10, okay, and the amylase in the drain fluid level is 40. Okay. So, that is more than 3 times, it is 4 times, then the patient has pancreatic leak or pancreatic fistula. You can anticipate occurrence of pancreatic leak or fistula intraoperatively, okay, in some cases preoperatively also. What are the predictive factors? If the pancreas is soft or the gland is fatty, then probably there are high risk of getting a pancreatic leak or pancreatic fistula. Imagine that as such the pancreas is a very soft organ, liver is firm but pancreas is very soft. So, if you try to suture a soft pancreas, the sutures are going to cut through. Okay. So, your anastomosis is not safe if there is a safe pancreas. Even when the pancreas is fatty, it becomes extremely soft. Okay. Then again it is not going to hold sutures. So, you can anticipate in which cases you can have a leak. Okay. If the duct is very small or you are not able to identify the duct, again the chances of pancreatic leak or fistula are very high. Okay. So, these are the predictive factors for pancreatic leak or fistula. Generally, you can manage pancreatic leak or fistula by drains. Sometimes you may have to put PCDs with the help of intervention radiologist. Very rarely there can be uncontrolled fistula, you may have to put additional drains or you may have to reoperate. In severe cases, you may have to do completion pancreatectomy. Okay. If you are giving your MCH exit exam, management of pancreatic fistula is going to be a long question. Okay. They may not ask you in INA SS or NEET SS or in your MS surgery exit exam, but if you are giving MCH exit exam, it can be a long question, management of post-op pancreatic fistula. Okay. So, be thorough with this topic. So, the revised 2016 International Study Group of Pancreatic Surgery has given a revised grading system. In 2016, International Study Group of Pancreatic Surgery has given a revised grading system for post-operative pancreatic fistula. Previously, we had A, B, C grading. Okay. Now, we do not have grade A. Grade A has been removed. Okay. Previously, which was grade A, now it is called as no post-operative pancreatic fistula. Okay. Let us discuss about this. So, what is grade A as per 2005 guidelines? Now, it is called as biochemical leak. Okay. So, there is no grade A now, it is biochemical leak, but if there is a biochemical leak, it does not qualify for post-op pancreatic fistula. And what is biochemical leak? There is increased amylase activity more than 3 times the upper limit of normal serum value. Okay. Remember that. Only this is found, rest all things are not found. Okay. Rest all things are not there. Okay. So, this is just biochemical. So, what happens is, whenever we do any anastomosis in the abdomen, first 2-3 days there will be some leak. Okay. But by day 3 it will heal most of the times. So, if you send any fluid from the abdominal drain in a patient of Whipple, the amylase will be elevated because it is a subclinical leak. Okay. If you start considering it as a leak, your morbidity count will go very high. Okay. So, that is why the grade A was removed, it was labeled as biochemical leak, and if there is biochemical leak, it does not qualify for post-operative pancreatic fistula. Okay. Moving on to grade B and grade C. Okay. Grade B and grade C are more serious than biochemical leak. What is the difference between grade B and grade C? If there is need of reoperation, if there is organ failure, or if there is death, then it will qualify for grade C. Otherwise, it is grade B. Okay. Have this concept. Grade C is the most severe variety of pancreatic leak or fistula. Okay. Grade B is intermediate between biochemical leak and grade C. And clinically relevant pancreatic leak or fistula fall in grade B in our clinical practice. Okay. Remember this, they can frame a MCQ on this, and you need to know if you are in GI surgery, HPP surgery, or you are working in a center which does Whipple surgery very commonly, then you need to know about grading of the recent grading of post-operative pancreatic fistula. Why was this done? Why did they label it as biochemical leak, not as grade A? Because when, like, if you send drain fluid amylase, okay, every Whipple's patient will have a biochemical leak, and when you calculate the morbidity, it was coming around 30-40%, okay, more than 35%. And if you tell a surgeon that the chances of POPF is around 35-40%, patient will not get operated. He will say, I will die with the disease rather than getting a surgery done and dying with the complication. Okay. So, to clear this confusion, so they removed the grade A POPF and labeled it as bioclinical leak, and biochemical leak does not mean POPF, and because of that the morbidity which was initially described in Whipple's procedure, which was around 37% or 40%, has come down to 25-27%. So, that was the whole logic behind removing grade A and labeling it as biochemical leak. The other morbidity is post pancreatectomy hemorrhage, okay, often written as PPH. It is rare but devastating complication. The mortality of PPH is around 40%. It is reported according to ISGPS 2007 classification, and the reporting is done considering timing, severity and location of the hemorrhage. Okay. The classification is either early PPH or late PPH. Early PPH occurs within 24 hours after surgery. It is usually because of perioperative coagulopathy or if you have done vascular resection, and it generally arises from the pancreatic surface or anastomotic site. Okay. Late PPH occurs after 24 hours. It is strongly associated with the post-operative pancreatic fistula. Okay. If there is a pancreatic fistula, imagine that the pancreatic juice is directly entering into the abdominal cavity, and when you are doing Whipple's procedure, you know that there are a lot of bare vessels sitting around the anastomotic site. This pancreatic juice, which has lot of active enzymes, is going to digest those vessels. Okay, and then the patient is going to have post pancreatectomy hemorrhage. What is the common site of post pancreatectomy hemorrhage? GDA, common hepatic artery, left hepatic artery, dorsal pancreatic artery, left gastric artery and splenic artery. Okay. Generally we see it is from the gastroduodenal artery. How you manage PPH? If it is early mild PPH, it can be managed conservatively. Late PPH, you have to do urgent CT angiogram and see from where the bleeding is happening. Most of the times the bleeding can be managed by intervention radiological approaches, either embolization or stenting. Surgical intervention is occasionally required. If there is luminal bleeding, you may have to do endoscopic therapy. Okay, sometimes there is bleeding from the stomach and jejunal anastomosis site or duodenum anastomosis site. Then you have to do endoscopic therapies. Okay. So, this is what we discussed now. Early hemorrhage less than 24 hours after the index operation, late hemorrhage more than 24 hours. Location can be intraluminal or extraluminal. What are the intraluminal locations? Suture line in the stomach, duodenum, pancreatic surfaces, or from the stress ulcers or pseudoaneurysms. Okay. Extraluminal, the bleeding is in the abdominal cavity. Okay. It is either from the arteries or venous, it can be diffuse, it is from the resected surfaces, it can be from the arterial or venous source, it can be diffuse bleeding, it can be from the resection area, it can be from the anastomotic suture line which is bleeding not in the luminal side but into the peritoneal cavity. It can also be because of pseudoaneurysm. Okay. Pseudoaneurysm can bleed intraluminally or into the peritoneum extraluminally. Okay. Based on the severity of the hemorrhage, you can classify it as mild or severe. When you will call it as mild? When there is small or medium amount of blood loss, the drop of hemoglobin is less than 3 gram per deciliter, doesn't need any reoperation, there is no invasive therapy needed. Okay. You just give blood and patient will be fine. Okay. Severe, when the drop in hemoglobin is more than 3 gram per deciliter, the patient will have clinical signs like tachycardia, hypotension, oliguria, hypovolemic shock. The patient will need more than 3 units of blood transfusion and it will require invasive therapy, either angiographic embolization or stenting or re-laparotomy. Okay. So, based on the severity of hemorrhage, you will classify it as mild or severe. Based on the time of onset, early hemorrhage, late hemorrhage, and based on the location, intraluminal and extraluminal. That is about post pancreatectomy hemorrhage, and all of this is as per ISGPS classification. Another important morbidity after pancreaticoduodenectomy is chyle leak. Chyle is basically combination of chylomicrons and lymphatic fluid. If you are doing any surgery near the pancreatic head and neck, there can be injury to the cisterna chyli which transports chyle, and you can end up having a chyle leak after surgery. The reported incidence of chyle leak after pancreatectomy is anywhere between 1.3 to 22.1%, and if there is a chyle leak, it causes malnutrition, poor wound healing, hypoalbuminemia and significant protein loss. What is the definition of chyle leak? According to ISGPS, chyle leak is defined as milky output from the drain or site or wound on or after day 3 after pancreatectomy. If you send the fluid for a triglyceride level, it will be more than 100 milligram per deciliter. Only grade B or grade C chyle leaks are clinically relevant. Okay, grade A chyle leaks are not clinically relevant. So, this is the definition of chyle leak based on ISGPS. How do you manage chyle leak? For grade A, it is conservative management. You will not give any fat, but you will add medium chain triglycerides. Medium chain triglycerides are safe in chyle leak because they are transported via portal vein and not via lymphatics. The other conservative options are putting the patient on TPN, using stomatostatin analogs with MCT diet, that is medium chain triglyceride diet. Approximately 75% of grade A chyle leaks will resolve. With MCT diet and octreotide or TPN, there is 100% resolution of grade A chyle leak. Timing of fat reintroduction in this patient is variable. You can either start once the drain output stops, or you can start after 2 to 6 weeks once the diagnosis of grade A chyle leak is confirmed. If there is persistent chyle leak, you may have to get lymphography with lipid oil. You can also do a operative ligation of lymphatic channels, and methylene blue use at that time will guide you. You can also do peritoneovenous shunt, for example Denver shunt, and this will recycle the chyle into the venous system. So, these are the management strategies for persistent chyle leak. Lymphography with lipid oil, which will cause inflammatory closure of the leak. You can do operative ligation of lymphatic canal, or you can also do peritoneovenous shunt for chyle leak. The other morbidities of pancreaticoduodenectomy, you can have anastomotic leak at PJ site or duodenojejunectomy site, which can occur in less than 5% of the procedures. You can also have infectious complications in the form of intra-abdominal abscesses or wound infections, and this can need percutaneous drainage or wound care interventions. Wound infections are more common if you are done preoperative stenting, and if there is any kind of leak, okay, it can present as intra-abdominal abscess. The patient can also develop portomesenteric venous thrombosis, which can lead on to GI bleed. Okay. Remember these other complications of pancreaticoduodenectomy. What are the late complications? Complications can be early or late. The late complications of pancreaticoduodenectomy can be marginal ulcers. There can be anastomotic strictures at PJ site or HJ site. Patients can have pancreatic endocrine and exocrine insufficiency. So, these are the late complications of pancreaticoduodenectomy. Moving on to controversies in pancreaticoduodenectomy. The first controversy we are going to discuss is palliative bypass in unresectable or metastatic disease. Okay. You have a patient, on CT scan it is resectable. You open the patient, then you find it is unresectable or there is a metastatic disease. What you have to do? Up to 10% of the patient are found to have locally advanced or metastatic disease at surgery, despite of high quality imaging present in today's era. You can also detect metastasis during staging laparoscopy. If the patient has GI obstruction or biliary obstruction, it can be managed endoscopically in today's era with the help of duodenal stent or ERCP with metallic stent. Proceeding with laparotomy or bypass when metastases are seen at laparoscopy is not indicated. Okay. You do a staging laparoscopy, you see that there are metastases. Okay. You do not have to open the patient, close the patient and send the patient to your medical gastroenterology colleague if they are having obstruction or if they are obstructive jaundice. If unresectable disease is found at laparotomy, whether to do bypass or no is a individualized decision. Okay. You have not done a diagnostic laparoscopy or a staging laparoscopy, you have already done a midline laparotomy and you have a dilemma whether you have to do a palliative bypass or you can just close the patient. It is an individualized decision. If you do not have your medical colleagues readily available to do a stenting, okay, then you can do a operative bypass. But if your colleagues are available and they are well versed with all these palliative modalities, you do not have to do, you can just close the patient. The options in these situations are either operative palliation or closure and endoscopic intervention if no prior biliary drainage has been done. There is no definitive data comparing survival and quality of life between bypass procedure and wrapping endoscopic stenting. The decision in these patients depends on symptoms, performance status and projected survival. If there is diffuse carcinomatosis or there is multifocal metastasis, there is no point in doing operative intervention. Better to subject this patient for endoscopic intervention. Patient with obstructive GI symptoms or patient who had prior duodenal stenting may benefit from surgical BI bypass. Okay? If you have a patient you have taken for open exploration and then you find that the patient had prior duodenal stenting and it is not working, or this time patient is having GI obstruction, probably you will be in more favor of doing a GI bypass. The patient has good functional status and low volume metastatic or locally advanced disease, again the operative biliary bypass will be reasonable. So, whether to do a endoscopic procedure or whether you will do a operative procedure in this kind of setup has to be individualized, okay? Especially when you have opened the abdomen. If you have done a staging laparoscopy, then you can stop the surgery there and send the patient to your medical gastronastic colleagues for stenting if indicated. The other controversy is pylorus preserving versus classical Whipple procedure. Pylorus preserving Whipple procedure was proposed that it will reduce the post pancreatectomy dumping and bile reflux. The initial results were encouraging, but randomized control trials have shown that there is no clear superiority of pylorus preserving Whipples over classical Whipple. Okay? In fact, couple of studies have found that the incidence of delayed gastric emptying is more with pylorus preserving rather than classical Whipple. The other controversy is pancreaticoduodenostomy versus pancreaticogastrostomy. Okay? Pancreaticoduodenostomy is the Achilles heel of Whipple's procedure. Okay? If they ask you an MCQ, okay, or if you are going for NEET SS interview and if they ask you what is the Achilles heel of pancreaticoduodenectomy, then it is pancreaticoduodenostomy. Okay? Because if there is a leak at PJ, it will lead on to lot of complications. There are some studies which have shown that pancreaticogastrostomy, instead of making a anastomosis between jejunum and pancreatic duct, you can make a anastomosis between the stomach and the pancreatic duct, that is called as pancreaticogastrostomy. The leak rates are lesser in pancreaticogastrostomy compared to pancreaticoduodenostomy. Few studies have shown that, but randomized controls have not proven this benefit. So, most surgeons in today's era favor pancreaticoduodenostomy. If the pancreatic duct is not identified, either you can do dunking into the jejunum or you can do pancreaticogastrostomy. Okay? Remember, pancreaticogastrostomy leak rate are lesser, but if the leak happens, then it is extremely difficult to manage. If you do pancreaticoduodenostomy, the leak rates may be higher, but the complications are easier to manage. So, remember this point. You will also do pancreaticogastrostomy when you are doing central pancreatectomy. Okay? Most of us will do pancreaticogastrostomy rather than pancreaticoduodenostomy if you are doing central pancreatectomy. Remember that point. The other controversy in Whipple's procedure is use of stomatostatin analogues to reduce the pancreatic fistula. We all know that pancreatic fistula remains a major source of morbidity after Whipple's procedure. We know that stomatostatin analogues can reduce pancreatic exocrine secretion, and by reducing pancreatic exocrine secretion, it can possibly reduce the risk of pancreatic fistula. In European trials, octreotide has reduced the incidence of pancreatic fistula after Whipple's procedure. In North American trials, there is no benefit demonstrated with octreotide. In MSKCC trial, pasireotide, which is a drug having longer half-life compared to octreotide, has reduced grade 3 or higher fistula rates, leak rates and abscess formation rates. Benefits are consistent across pancreaticoduodenectomy, distal pancreatectomy, in presence of dilated pancreatite, in presence of pancreatic duct dilatation or in absence of pancreatic duct dilatation. Okay. So, remember that octreotide is not only used in pancreaticoduodenectomy, you can also use in distal pancreatectomy, you can also use in central pancreatectomy, and it can be used in dilated pancreatic duct and non-dilated pancreatic duct. So, what do we do in our practice? We use octreotide selectively. If there is a high risk of developing pancreatic fistula, when the pancreatic duct is undilated or pancreas is very soft, we use octreotide selectively in these patients. So, that is what the practice being followed by us. Role of minimally invasive pancreaticoduodenectomy. First laparoscopic PD was performed in 1994. After that, there were few case reports or small series which demonstrated the feasibility of minimally invasive pancreaticoduodenectomy. There was a large US series published which had 65 laparoscopic pancreaticoduodenectomy reported. The morbidity was 42%, reoperation rate was around 5% and mortality was 1.5%. The updated series of 108 laparoscopic pancreaticoduodenectomy showed shorter median hospital stay and earlier delivery of adjuvant therapy in patients who have undergone pancreaticoduodenectomy laparoscopically or robotically compared to open PD. But remember that the procedure of laparoscopic or robotic pancreaticoduodenectomy requires advanced pancreaticobiliary laparoscopic expertise. It has to be done in a high volume center. The complexity currently laparoscopic Whipple surgery is not widely adopted. Robotic PD is proposed as an alternative or adjunct to laparoscopic PD. It allows meticulous vascular control and complex reconstruction. There are large robotic PD series which have been published, but remember currently open PD remains standard of care. Okay? If you are not trained to do a laparoscopic PD or robotic PD, don't get disheartened. In today's era currently open pancreaticoduodenectomy still remains a standard of care in patients with pancreatic cancer. The other controversy is anticolic or retrocolic duodenojejunectomy. Delayed gastric emptying is common after PD, we have discussed extensively. Anticolic reconstruction may improve gastric emptying compared to retrocolic reconstruction, but based on the current literature, there is no difference between anticolic or retrocolic duodenojejunectomy. Okay? Drain or no drain. Drain are routinely used due to high risk of pancreatic fistula in patients undergoing pancreaticoduodenectomy, but we also know that drains are associated with increased infection, pain and prolonged hospital stay. Randomized control trial at MSKCC did not show difference in complication rate with or without drains. Multi-institutional RCT was terminated early because no drain group had increased morbidity and 4-fold higher mortality. Drains will mitigate adverse impact of pancreatic fistula. If you are working in a high volume center, you need not put drains because you have advanced intervention radiology support available all the time, endoscopy specialty available all the time. But if you are working in a smaller center, then surgical drains should be considered as standard of care. Remember this. Okay. Role of irreversible electroporation. It is investigated for locally advanced non-resectable pancreatic cancers or for margin accentuation. It preserves collagen-rich structures while killing tumor cells. It is proposed to improve local control and overall survival in patients with pancreatic cancer. The utility in management of locally advanced pancreatic cancer still remains to be determined. So, irreversible electroporation, remember briefly about this. There can be an MCQ in INA SS on this. Let us discuss couple of MCQs. A 62-year-old man presents with obstructive jaundice, weight loss and pruritus. Imaging shows mass in the head of the pancreas involving intrapancreatic bile duct, but there are no distant metastases. Which of the following is the most appropriate surgical management? We know pancreaticoduodenectomy was Whipple's procedure. 58-year-old female with pancreatic head adenocarcinoma is planned for Whipple procedure. CT shows peritoneal metastasis and poor performance status. What is the next best step? So, this patient is not fit for surgery. So, what you will do? You will do palliative chemotherapy and endoscopic stenting. During exploration for Whipple, a pancreatic head mass is found encasing less than 50% of the portal vein circumference, which is the most appropriate intraoperative management. So, if there is a vein involvement, you can resect the vein and do a reconstruction or repair. Okay? So, do not have to worry about it, just do a resection of the vein and reconstruct it. 64-year-old man undergoes Whipple's procedure. Post-op day 5, his drain amylase is 4 times higher than the serum amylase. He remains hemodynamically stable. What is the diagnosis? The answer is very simple: post-operative pancreatic fistula. A patient develops milky drain output on day 4 after Whipple procedure. Drain fluid triglyceride level is 180 milligram per deciliter. What is the most appropriate next step? So, patient here has chyle leak. Okay, day 4, more than day 3, we take it as chyle leak. So, they are asking you the management. The management here is start the patient on medium chain triglyceride diet, MCT diet, and you can also use octreotide in this patient. Okay, so that is the treatment in this patient. With that, we come to end of this module. Thank you.